Welcome everyone to this lecture on metabolomics, especially talking about in the dietetic practice. Now, metabolomics is actually a newest of the omnic sciences. After we spoke about genomics, transcriptomics, and proteomics. So, as a future dietitian, understanding metabolomics will allow you to interpret functionally, nutritionally assessments and understand why patients respond differently to dietary intervention. So, we'll cover of what metabolomics is and how to read the metabolics panel in the real world. So, what is metabolomics? Metabolomics analyzes the complete set of metabolites, that is, small molecules, similar amino acids, fatty acids, organic acids, sugars, vitamins, sometimes even neurotransmitter precursors. So, what is it? How is it different from genetics? Unlike genetics, genetics is fixed. Metabolomics is dynamic. Why? Because it changes with diet, with stress, with medication. Even changes happen because of the change of your gut bacteria, your lifestyle changes. Now, this makes an incredibly relevant to our practice. So, talking about the omnic ladder, genomics tells you instructions, okay, of the genes, which is fixed. However, metabolomics tells you what the body is actually doing it right now. So if you take an analogy, genomics is like you get a recipe book, you're reading the recipe. But when you talk about metabolomics, it is the actual meal that is prepared and what is cooked. So as common as a sample, we would say that serum plasma, which is a systemic metabolic snapshot. In the urine, the kidney filters metabolites and excretes it. So, the overnight fasted urine, therefore, it is often used. Talking about the stools, the microbiome derived metabolites, especially to check the short chain fatty acids. So, now can you think of a metabolite that you already measured in clinical practice? Correct? One would be the blood glucose, cholesterol, uric acid. So, what are these? These are all metabolomic measurements, and therefore we understand it from the metabolite point of view. So, metabolome is not fixed like your genes, and it changes based on what you eat, changes based on your environment, your current state. Now, think of it like a snapshot where all the tiny molecules in our body are there right now. Okay, so metabolomics is how we capture and study the snapshot systematically. So the key insights are not just to look at the molecules in isolation, but it is to connect them back to your genes, so your proteins, your lifestyle, which is all very dynamic, and this dynamic nature is what makes the metabolomics so powerful to understand health and disease. What are the key metabolic pathways? Talking about the key metabolic pathways, the first thing that comes to your mind is branched chain amino acids or amino acid metabolism. Leucine, isoleucine, valine. Now, these are the branched chain amino acids. What happens to it in insulin resistance? Or what happens to BCA in obesity? It is elevated. Okay, the homeocysteine is a methylation marker, and when you see a high level of homeocysteine, you associate it with B12 or folate insufficiency. So there is direct actionable with the dietary intervention. Similarly, if you look at aromatic amino acids, which are they? Phenylalanine, tyrosine, tryptophan. These feed the neurotransmitter synthesis. and therefore it is linked to mood, your gut brain axis. Talking about fatty acid metabolism, that is the uh, acyl carmides, as well as they reflect the mitochondrial fatty acid oxidation. That is when you find that there is elevation of short chain, and maybe they indicate that the mitochondrial dysfunction or the micronutrient deficiencies. So when you get something like a ketone bodies rise with fasting, so that means there is carbohydrate restriction, or there is a diabetic ketoacidosis. So this distinguish is very clear. In a carbohydrate metabolism, what happens to the elevate and lactate ratio? They there is elevated, and when there is an elevation of the pyruvate or lactate ratio, which indicates that uh, there could be a thiamine deficiency, which is critical in clinical population, because the TCA cycle intermediates, that is the citrate, succinate, and the fumarate, they all reflect the mitochondrial efficiency. So, three pathways are interconnected. And even if one pathway gets disrupted, it will affect the other. So, a disruption in one, like say, if you say the amino acid catabolism, which alters the TCA, okay, and metabolomics, they capture this system level very, very well. Coming to understanding how this metabolomics actually work, okay, what is the technology? Now, the first thing that is done is the sample collection. Fasting state basically dramatically affects amino acid as well as the lipid profile. So, what is usually asked is about 8 to 12 hours fasting, which is required. Hemolysis, that is broken red blood cells, invalidates results, okay, and therefore the labs need to flag this. The other test that could be of importance is urine, which is required specific gravity adjustment as the concentration varies with the hydration. So, usually it is the morning urine sample that is taken. Number two, the step two, what you'll do is sample preparations. Of course, we don't need to know this, but it is for internal standards that help to exist and explain why this test should be reproducible. Step three is the technology. Again, nothing to do really with us, but since this is a new science for us, let us look at how this liquid chromatography and the nuclear magnetic resonance, that is the NMR, they are working. Also, we have bioinformatics, that is the pathways that map the software. So these are softwares which are used, and they are used to give the report. So the patient will receive an interpreted report to understand the pipeline. What is the difference between targeted and untargeted metabolomics? This is very important concept that will distinguish, because it determines what kind of report you will receive. Now, in a targeted metabolomics report, which the clinician will mostly use, you will exactly know what you are measuring. So the lab has a validated reference range. So for example, the A-cycarnitine and that profile, if you ask for, you will receive the concentration of certain reference ranges, which can be directly acted upon. When you talk about the untargeted metabolomics, which is generally used in research, they use they cannot you cannot say that. In fact, there are many research papers which report these untargeted findings. We do not need to understand all these things in great details, because for us the report reading is very, very essential. But if the patient brings a metabolic report from a private lab, and to check whether it is targeted or untargeted, you should be able to say. So the when it is targeted, it is quantified with reference range, and untargeted is a relative intensity. Okay, there is no particular reference range that is used, and therefore the targeted one is more actionable. Coming to the report anatomy, let's look at what the section A will tell you. It will tell you about the demographics of the patient, a little bit of the age, the sex, the creatinine levels, amino acid levels. Uh, because it's a non-fasting sample, it could alter the glucose, the triglycerides, and some amino acid levels. If fasting status is not confirmed, then you have to be careful, because there is a difference in the reports in the fasting and the non-fasting state. Section B is the QC metrics, that is the internal standards recovery, uh, below 80% or above 120%, which may indicate extraction failure. Okay, like hemolysis release or intracellular metabolites. Okay, not so much used for us, but you should be able to understand what it means. The section C will give you the metabolite table. Okay, it will teach the flag system. That is, L is below reference range, H is above reference range, N means normal range. Not all the flags are clinically significant. Okay, you have to assess it in the context of the patient and in the context of the whole panel itself. Now, some labs use percentile ranking. Okay, so some labs will say 82nd percent, or they will give you the reference range of the population. Then is there section D, which will give you the heat map, like a heat map. So, what is a heat map? When you talk about the colors, so red will be elevated, blue will be typically depressed. Okay, so you can use this as a visual guide, and the section E will show you the interpretation notes. So you will read what you need to interpret and in the context for dietary intervention. So reading the metabolite table. Now this is basically a slide which will give you a little understanding of how you should be reading the report. So flagged results and their clinical meanings. Homocysteine 18.4 millimoles is, if you look at this report, it shows high. That is, elevated total homocysteine strongly suggests impaired methylation. So dietary causes could be either folic acid deficiency, it could be B12 deficiency, it could be B6 riboflavin deficiency. As a dietitian, your action here would be to assess dietary intake first, whether the patient is eating adequate foods with these nutrients, adequate green leafy vegetables, legumes, eggs, if the patient is vegetarian. So therefore, in those cases, you check B12 and serum folate level as a confirmatory test. So whilst you look at it as a metabolite, you also can do a parallel check where the patient has already got a report of B12 and folic acid and whether there is any correlationship. The other report is the methyl melanonic acid, which is about 0.45 millimoles, which is again high. Normally we'll say the MMA is most sensitive functional marker for the B12, and it rises even when the serum B12 is normal. So this is the difference in your report between a serum plasma report and the metabolomic report. So in a metabolic report, if you find that the MMA is 0.45, which is high, it means that it is a very sensitive marker, that even if the B12 appears normal, there is a problem with the metabolite, and therefore this action needs to be taken. So this, combined with the elevated homocysteine, which will strongly suggest that the functional B12 is insufficient. Remember, here we are talking about the functional B12 which is insufficient. The plasma will have enough of B12. You may see a normal report. But when you are actually looking at the functionality in the metabolic report, you will know that the dietary B12 intervention and supplementation is required for this patient. The polyglutamic acid, which is, say again, if it was 12.1 or more, it is high. Now, when you talk about what is the polyglutamic signal, this is for glutathione depletion and the N-acetylcysteine insufficiency. We know what glutathione and NAC are, and they indicate the oxidative stress. So, so for oxidative stress, or sometimes even when there is an excessive paracetamol usage. So, what is the dietary action? Here, the dietary action would be that increase the sulfur rich foods. What are the sulfur rich foods? Garlic, onion, cruciferous vegetables, some amount from whey proteins as well. The next one, we'll talk about the quinolinic acid. If it is 1.8 millimoles, it means it is high, and this basically lies on the kynurenic pathway, that is the branch of the tryptophan metabolism. So elevated quinolite is associated with inflammation, neuroinflammation, and increase of the IDO1 enzyme activity. So the dietary action, that is the anti-inflammatory diet, which comes, say, from omega-3 fatty acid, considers that tryptophan containing food. So what we are trying to say here is that always look at the clusters of finding and not the individual metabolites in isolation. So if you find the cluster of finding like homocysteine plus MMA elevated together, there is a strong evidence that B12 deficiency rather than only one activity. So therefore, you have to understand how these impressions are made. So the pathway heat map interpretation. What is a heat map? It is basically something that you look at it and you know your fast clinical interpretation. Three-step approach. First, you scan and look at the report. Look at for reds. Any way where you find that significantly elevated are something that's high risk. Blues are significantly depressed pathways, and again here clusters. When we say that look at metabolites in clusters, the step 2 is look at the clusters. Do elevated pathways make biological sense together? Yes. So when you see, I said methylation and antioxidant pathways both are disrupted, it strongly suggests that B12 folate acid deficiencies are driving the oxidative stress. So therefore, when you talk about the kynurenine pathway, the tryptophan being stunted towards the neuroinflammatory away from the serotonin, and therefore the potential mood implications. This is very important concept for people who are having neuro disorders, because when we talk about ADHD, we talk about other implications. Here is what we are looking at. We are looking at these metabolites which interact. Then is the contextualization. So does this patient fit in the patient's pictures, given the dietary history, the symptoms, whether the patient is veg, non-veg? Ask if the patient has got a cognitive fog or is fatigued. Now these metabolomic findings, they may give you a better nutrition pictures. Commonly, pitfalls would be that you focus on single metabolite, you may miss the pathway story. But if you look at the heat map, that is the reds together, the yellows together, the greens together, this will prevent you from looking at a story in a single isolated form. Okay. Coming to the nutritional application, the side positioning metabolomics within the daily scope of dietetic practices that you will find in personalized nutrition. Traditional nutrition advice is population based. Okay, what is a population based? When you get guidelines, what does the guideline says? Oh, everybody has to eat 5 fruits and vegetables every day. But if you're looking at highly personalized precision metabolomic nutrition, you will metabolomics will reveal and say why that the same diet produces different outcomes in different people. So there are many twin studies that shows that identical diets produce different glycemic responses. So metabolics can explain this variation. If you look at the gut microbiome, like the stool short chain fatty acid, you analyze is the analysis is available in a clinical test. So butyrate production is linked to the Firmicutes species. So low butyrate is compromising the gut barrier, and therefore dietary fibers matter. Resistant starch favors the butyrate production. When you talk about, say, obesity, metabolic syndrome, in these cases, as we talked about it in the first slide, there is elevation of branched chain amino acids. Okay. Now, we all propagate branched chain amino acids for liver diseases, for other things, but is excess also good or bad? So yes, here when we talk about BCA in patients in obesity, it is like a double-edged signal. So one, it comes from dietary excess, that is some adipose tissue proteolysis. So metabolomics can differentiate between the metabolically healthy obesity and metabolically unhealthy obesity. So clinically, these are very different profiles. In sports nutritionist, in nutrition as well, that is the acyl carnitine, which is depleted with the increased long chain acyl carnitines, which suggests that there is insufficient or impaired fat oxidation. Therefore, these guides to carnitine supplementation decision is given for the endurance athletes. These kind of kynurine pathways, which are very important in the mental health issues, it is activated by the inflammation. So patients with depression, they have shown that there is elevated kynurine pathways, that is the KYN-TRP ratios. uh, People dealing with these problems can use supplements in this order to get their metabolites corrected. So, dietary omega 3 suppression, they suppress the inflammatory IDO1 activation and they redirect the tryptophan towards the serotonin synthesis. So when we talk about the benefits, even for pediatrics, okay, there is like a newborn screening that happens where you can find out the metabolomics. Let's look at a very simple case for understanding what we spoke. So if I say Sarah's serum B12 is 215 millimoles, and this appears within the more normal range. So if you look at the lab reports will tell you around 180 parts per millimole per liter is normal. So she is told that it's normal and she does not have to worry about her B12 levels because it is above 180. Now, this is when you look at the B12, which is a poor functional marker. So, it measures total B12, including inactive analogs, and functional deficiencies can occur even in a normal serum level. So, therefore, her symptoms, when you ask for what are her symptoms, fatigue, brain fog, low mood, and are classic B12s and folic acid deficiencies. So the OCP usage, that is the estrogen containing contraceptives, are known to deplete riboflavin, that is B2, B6 and folate, that is B9. It is also known to delete magnesium and zinc, and this is therefore very important to understand that if a person, to top it, they are on a vegetarian diet, that means with inadequate dairy, eggs, and they are not taking any B12 supplementation, this is a classic setup for a gradual functional B12 depletion. So therefore, based on the case history alone and what you read at reports, it may not be giving you the true picture. When you look at a metabolic reports, you will be able to create what makes the case more sensitive. So, in Sarah's findings, this is the analytics of her case study. And you look at the recognition, there are three distinct clusters. Now, when I said we have to look at the clusters, don't look at a report in isolation, look at it in a cluster. The cluster for B12, okay? B12 will not come alone. Similarly, it will come with folic acid functioning, it will come with homocysteine, it will come with MMA. If you look at the cluster, all the three are high. Okay, so homocysteine 21.3, MMA 0.52, the Figlu is also 8.9. Okay, now homocysteine requires B12. Homocysteine also requires folate, B6 for its metabolism. Therefore, elevated, it means that methylation, there is a bottleneck there. MMA only elevates when B12 is functionally deficient. Even if the serum is okay and the MMA is high, it means that there is a functional deficiency. The FIGLU, that is specific marker for functional folic acid, that is functional folate, deficiency of form immunoglutamate acid. This accumulates when the folate is insufficient for histidine catabolism. Therefore, this triad of it provides a very strong evidence than looking at your serum B12 alone. The cluster, let's look at the other cluster. Oxidative stress, polyglutamic acid, 14.2, which is high. Now, this reflects glutathione depletion. So, what is glutathione? It is the body's primary antioxidant. So, there is B12 deficiency, which impairs the methylation, which impairs the glutathione regeneration, and the OCP, which is also increase the oxidative burden. So this cluster, this is one cluster. So there is tryptophan serotonin imbalance, there is the quinolinic acid imbalance, that is the tryptophan is being stunted towards the kynureninic pathway, which is pro-inflammatory. So instead of the serotonin pathway, it takes the kynurine pathway, which is a pro-inflammatory pathway. Now inflammation plus B6 depletion, okay, plus there is low HIAA, and this is not basically only for a psychiatric diagnosis. It is a biochemical finding that dietary intervention can address. You can look at it from a different angle, because when you are looking at metabolomics, why is it different from looking at a normal report? Look at a normal B12 report. It is between 180 and 212. But you match that report with your metabolic report. And in your metabolomic report, you look at it as a cluster. Look at B12, look at your, the other parameters. Look at folic acid, B6, B2, B9, and then you make your clinical decision. Okay. So serum B12, 215 millimoles per liter looks borderline, and you might just dismiss the patient off, and you may tell the patient, you're borderline, you seem okay. And if you look at the levels also, it is such a high range. So MMA, which is 0.52, which is basically it's elevated. Also the metabolics, they change the clinical picture from the fine to you need a definite deficiency. Okay, so you know that now, after you have read this Sarah's report, you know that she actually needs a B12 intervention. Okay, then when you look at her serum report alone. Looking at Sarah's interventional plan, prioritize B12. Methylcobalamin is preferred over the cyanocobalamin for methylation purposes. It enters the methylation cycle more directly. Why the specific foods? Offer her eggs if she eats eggs. Give her some other, these days there are fortified B12 foods available. nutritional yeast is available. She needs at least 2.4 micrograms per day, ideally from about 10 micrograms of food or 1000 micrograms of supplementation. MMA retest at 8 to 12 weeks, which is essential to confirm the response, uh, and normalize homocysteine. Folate, why methyl folate, that is 5 methyl not folic acid. um, Enzyme polymorphism, we know about this in from the genetic reports as well. Figlu is a folate specific marker. Okay, it confirms that folate intervention is needed successfully. Prioritize glutathione. NAC provides rate limited cysteine. Then introduce rich foods, B6 rich foods, B12 rich foods, B2 rich foods, cruciferous vegetables, green leafy vegetables, tryptophan and serotonin, which are, and introduce anti-inflammatory omega-3. Okay, DHA, EPA, it suppresses the IDO1 and the enzymes are diverted to tryptophan. Then follow up for the retest as maybe 6 to 8 weeks. Coming to the outcomes, you literally, like at week 4, you see week 12, the MMA has a short half life and the tissue indicator. So therefore the transitions should be accordingly. If MMA normalizes but homocysteine remains elevated, okay, sometimes it happens like that. If the FIGO normalizes but MMA remains elevated, okay, that means folic acid correction, B12 is still needing attention. Serotonin pathways are redirected directed successfully. So in a metabolomic guide nutrition, you have to quantify targets to hit, not test for symptom improvement. Okay, this is basically, we are talking of a paradigm shift from eat more green leafy vegetables to retest MMA in 12 weeks and confirm greater than 2.7. So this elevated dietetic practice to precision medicine is important. Now, if Sarah shows no response at 12 weeks despite adherence, okay, what will you do? You will also consider the MTHFR, homozygous polymorphism, which needs higher methyl folate doses. Pernicious anemia, intrinsic factor deficiency, B12 absorption gets impaired. Here, IM injections are needed. Medication interaction, check for that. Check for metformin, check for PPIs, check for depleted B12. Okay, these, though they may not be on a medicine list, but in case if you have missed it, maybe even after you have done so much and it is not elevating, there could be some problem. Always refer to the gastroenterologist if you feel that there is some kind of a malabsorption issue. Coming to the stress hormones, cortisol and adrenaline, they are released during the blood draw and affects the amino acid profile. Even 30 minutes of exercise before the test can elevate your branched amino acid and the acyl carnitines. Now, always ask, was the patient fasted when the sample was taken? Was the storage protocol followed properly? Because sometimes these are important questions to ask, because some commercial labs could have different reference population. Okay, correlate is not the reason or not the causation. So if you say that vitamin D metabolites in winter could be insufficient because of the insufficient sun exposure, dietary deficiency, malabsorptions, metabolomics can actually distinguish without dietary history. So always integrate metabolomics with 24-hour dietary call, food frequency test, anthropometrical measurements, right? The cost, I don't know exactly the cost. It could vary with different labs. Your institution also could be having these tests to this thing. So you can check online what is the costing. Now, in dietetics, why food body mark food basically biomarkers, diet exposure. Every meal creates a metabolic footprint, fingerprint, a unique chemical signature. Metabolomics can detect these signatures in the blood and urine and stool. And this is how we measure what people actually ate at even a molecular level. Metabolic response. Now, the body doesn't just absorb food actively and process it through the metabolic pathway. This processing creates an intermediate compound we can measure in real time. And these measurable compounds tell us how the body is responding to the dietary inputs. Now we see the same metabolomic patterns repeated linked to specific food and diets, and they become the validated biomarkers. Now these biomarkers can be used in clinical nutrition. They to bridge the gap, you know, with what someone eats and what measurable health outcomes to feed. We can now objectively measure the biological impact of the diet through metabolomics by moving the nutrition from subjective reporting to an objective biomarker data. Also, two main analytic techniques. Just thought it would be a good idea to tell you what are the analytic techniques that are used. One is the mass spectrometry. Okay, maybe we don't really need to know the details of it, but this is just for knowledge. And the other one is the NMR spectrometry. Okay, this is how the lab works analysis happen. And but why should it matter to you as a dietitian? Now, understanding these steps will helps you know which findings are solid and which might have been limitations. So there are different techniques that have different strengths and computational analysis, which there could be variables. Okay, so metabolomics is not just one test; it is a whole pipeline of each stage affecting how trustworthy this final report is. So how what? Let's look at it at one glance. Walk through each step. You can do the quality control. You can quantify. You can do so many things just for knowledge sake. The two lenses we spoke about, the targeted and the untargeted. Okay, think of this as like a casting a wide net, okay, and scanning through thousands of different molecules at once, and then we take mass spectra and we get the match for them against the big reference database which is identified. Now this approach is perfect when you are exploring and you don't know what you're looking out for yet. You're just this thing. When you say targeted is you know what you're looking out, right? And we predefine, we know the metabolite that we want to see and want to measure. There could be thousands of them, okay, because we know what we are looking, we can ask those questions. So it is faster to basically to understand untargeted when you are discovering, when you're just finding out what could be the metabolite. But that's when you use the untargeted. But when you are using a specific metabolite, you call it targeted. Identify the study type, ask yourself the question, check the platform, scan the identification, verify. Okay, this is for knowledge sake. uh, don't treat metabolites clusters as standard findings. Okay, you have to connect with them to the happenings in the body also. So if high chain branching amino acids is not just a number, they are signaling that impairs the breakdown, or it also impaired breakdown, or it's talking about the insulin resistance. So why does it mean, what does it mean? It's that when there are hundreds of metabolites, these methods, they comprehend the complex data, okay, and helps you see what other values that you are looking at. So we do the metabolite reporting, you do the clinical interpretation, and then you give the personalized nutrition plan. So when you're doing this, there is a raw output from the lab which we are looking at the actual data, the pathway maps that show how metabolites interact with the statistical significance of what we are seeing. Then you do the you apply it, we recognize the patterns, the data determines the pathway, and actually it matters for that person. Not every finding will be clinically relevant. Some would be, some would not be. And then we translate those into insights or real dietary changes. So specific food targets, you can give those targets to the patient. Some questions for your brain test. So elevated homocysteine, normal MMA, folate, or B6 deficiencies, not B12. So if MMA is B12 specific, normal MMA is equal to B12 sufficiency. Homocysteine requires both B12 and folate. Okay, and if only folate is deficiency and MMA stays normal, but the homocysteine rises. So in vegans, folic acid is often adequate. Okay, because they have abundant plants. So isolated folic acid deficiency is less common than the B12, but B6 deficiency also needs transfiguration of the homocysteine to cysteine is possible. So management is to assess the dietary folic acid, B12, Figlu, and test and confirm. Then metformin induced B12 depletion. So metformin blocks the calcium dependent absorption. Okay, and therefore B12 intrinsic factors complex are affected, and 30% mostly of long-term metformin users. Okay, B12 may stay normal, but MMA rises, and this is a classic deficiency we spoke about. Low, okay, this is again for carnitine deficiencies. Okay, next. Okay, so the metabolism is your window to nutrition at the biochemical level. It bridges the gap between dietary intake and the physiological function. Before ordering or interpreting a panel, always ask, is the targeted or untargeted? Does it have to be validated against a reference range? The systematic reading approach is a clinical skill. So practice it with every report, just as you would practice with any ECG or blood parameters. Like we saw in the Sarah's case, the metabolomics changed the management from borderline B12 to watch and wait to a definite functional deficiency intervention now. Okay, treat to target is a concept from the pharmacy and cardiologist, and metabolomics brings it to nutrition. Okay, treat to target. What gets measured gets managed. Not every patient needs a metabolic big panels. It's expensive. So your job is to identify who would benefit most from it, whether it is the results will change your management. Okay. So the field of nutritional metabolomics is growing very, very rapidly. And as a dietitian, we need to get upgraded. We need to understand our reports better, because you never know in front of your desk which patient will come with what report and how you need to interpret to that patient properly. Okay. So it is very likely that these skills that you have learned and you're practicing today will make an effective use for your as a tool for your practice. Okay, so I would be very happy if you get in touch with me. We can do much more on both metabolomics and the nutrigenetics, and there is a course, there's a book, you can also read it. Thank you so much.